Hello. Hello.
Yeah, you are ready?
Yes, sir. Am I audible, sir?
Yes, audible. Okay. You can start presentation.
So, good morning, everyone. Today's topic of discussion is ophthalmoscopy. So, it's a clinical examination of the interior of the eye with the help of ophthalmoscope, and it is primarily done to assess the state of fundus and to detect the opacities of the ocular media. So, there are four ophthalmoscopic methods of examination. We have distant direct ophthalmoscope, we have direct ophthalmoscope, we have monocular and binocular indirect ophthalmoscope. Hermann von Helmholtz in 1850, he first described ophthalmoscopy. Direct ophthalmoscopy, let's start with the principle. So how we see the fundus from the direct ophthalmoscopy? For that, we first take the example of emmetropic eye. So as you can see in the first image, light, so the conversing beam from the light source in the direct ophthalmoscope, it reaches the uh, patient's eye and illuminate the retina. Then the rays emerge from that illuminated retina, and since the eye is emmetropic, these rays become parallel, and when the observer's eye come in the path of these parallel rays, this rays enter into the observer eye with the viewing hole in the ophthalmoscope, and since the observer eye is also emmetropic, it will focus on the retina of that observer, and thus then this image that is formed on the retina, as you can see in the second picture, it the observer will project it at the working distance of 25 centimeter, and thus you will get an erect and the virtual image. Now this is the condition in the emmetropic eye. Now what happened in the myopic eye? The emergent rays is conversing, so the it will focus somewhere in the vitreous of the observer eye. So what we can do here is we can place the concave lens uh, we can place the concave lens in the path of emerging rays so that it will become parallel, and then it will again focus on the retina of the observer, and the image will form. And in the hypermetropic eye, since the rays is divergent, we can use the convex lens, and which make these rays parallel, and it will again focus on the patient's retina. So this is the principle in the direct ophthalmoscopy. Now, what is the source of light used in ophthalmoscopy? Earlier, the first source of light was candle, then it will upgraded to the gas light, then external electric bulb, and then inbuilt electric bulb. Now we use LED halogen xenon technology because they have a brighter illumination and a longer life. Now we have discussed that we correct the refractive error by placing the concave and convex lenses. So how do we place the convex or concave lenses? For that, we have the Rico's disc, also known as lens disc, in the ophthalmoscope, which have the concave and convex lenses. So what you have to do is, when you are focusing on the retina, when you are seeing the retina and the image is not focused, you just have to turn this disc till the time the retina become clear. uh, Now how the distance between the observer and the observed eye matters. So when you see the patient eye from far, only the number of rays entering into your eye will be less, so you will see only red glow that we get when we do the when we do the direct ophthalmoscopy at 1 meter, we get the direct glow. Then when you go nearby, like slightly nearby, like at 20 to 25 centimeter, now you will also see the opacity, these as a black shadow. These opacities may be due to the cataract, maybe due to the iris pigment over the lens. So now you and this is the principle in the distant direct ophthalmoscopy. So in this, at this distance, you can also find out, you can also find out the position of that opacity. For that you have to ask the patient to look up and down. So if and see that opacity, if that opacity doesn't move, that means it is in the pupillary plane. If that opacity is in front of pupillary plane, it will go in the direction of the movement of eye. And if the opacity is behind the pupillary plane, it will go against the direction of movement of eye. Now when you go close to the patient's eye as possible, then you can see the clear fundus image. So now how we correlate these findings in the direct ophthalmoscope. So this is the fundus image, and we know that all the thing here is not in the same plane. Like we have the depressed optic cup, then we have relatively elevated neuroretinal rim, and then we have the flat retina. So all we have three plane here. So as you can see in the second image, as we put the neutral lens while doing the direct ophthalmoscopy, the flat retina is focused, but the depressed optic cup and the elevated neuroretinal rim is not focused. And when we put the minus lens, then the depressed optic cup is focused. And when we put the plus lens in the third image, then the elevated neuroretinal rim is focused. Now we use this concept to differentiate between the depth and the height of the lesion. Like in the first picture, when you put the minus lens, optic cup has been focused, and if there is any hole or excavations, that will also get focused. And when you put the plus lens, the elevated areas like edema, cyst, retinal detachments, or the membranes, you can see those things with the plus lenses. So this concept is very important in direct ophthalmoscopy, as this is the monoocular method and we do not have stereoscopic view in this. One thing also need to be know that the observer's eye must be emetropic. If there is any refractive error in the observer's eye, it has to be corrected with the contact lens or with the glasses before the procedures. Otherwise you will get the false result. Now what happen if the patient with astigmatism come? So let's say one patient come and we put the minus glasses like in the second images. So all the poles of the disc has been cleared, but the vertical pole is blurred. Then if we put the plus glasses like in the fourth image, all the pole of the disc has been cleared, but the horizontal pole is not clear. That means at one time we can focus only one meridian. We can neutralize only one meridian. So this is the case of astigmatism. Now, what is the magnification in direct ophthalmoscopy? So in the direct ophthalmoscopy, examiner uses the optics of patient's eye only as a simple magnifier to look at the retina. And the optics of emetropic eye is approximately 60 diopter. So we use the formula of simple magnifier, that is the dioptric power of eye upon 4, that is approximately 15 times magnified. So we get the erect, virtual, and 15 times magnified image is formed at the working distance. Now, what happened in myopia? Total power of eye is more than 60 diopters. So this 60 diopter plus whatever correcting minus lens we have put, the sum of this will be based on the principle of okay, the magnification will be more than 15 times. Then in hypermetropia, total power of eye is less than 60 diopter, and this less than 60 diopter plus the correcting plus lens, it will give the magnification of less than 15 times. So in myopia, we get more than 15 times of magnification. In hypermetropia, we will get the magnification of less than 15 times. Now, coming to the field of vision, so even being as close to patient as possible, the peripheral rays that are coming from the peripheral part of patient retina, that do not enter the examiner's pupil. So it restricted the field of vision to approximately 5 to 7 degrees. Now you can also ask the patient to look up, down, or nasally or temporally, and try to concentrate on to see the peripheral retina, but then there will be the lots of distortion and the image will not be clear. Then you can also dilate the patient and see the peripheral retina, but in that case also you can see only up to the equator, not beyond that. Now the various apertures in the direct ophthalmoscope. So we have a large light aperture for the dilated pupil, we have the medium light aperture for the normal size of pupil, and we have the small light aperture for the miotic pupil. So why we here the question is why we cannot use the large light in this miotic pupil, because then these lights will fall on the iris and then it will reflect back and cause glare. Then sometimes there will be the there will be the half of the opacity in the pupil, and on that cases we uses the half light aperture. Then we have some filters, like we have red free filter, in which we can see the vessels, the hemorrhage, the RNFL defect, and then we have the blue light filter, which we can use in corneal staining. Then we have grid also to measure the dimension of any lesion. Now procedure. So this direct ophthalmoscopy has been carried out in semi-dark room, and patient is asked to sit comfortably and looking straight, and the examiner has to be stand on the side of the eye to be examined. Now first do the distant direct ophthalmoscopy and see the red glow. Then move as close to patient eye as possible. Assess the lens opacities, the vitreous opacities. Then slowly go forward and focus by twirling the dial for Resco's disc, uh, and then see the posterior pole, see the disc, trace the vessels up to the equator, and see the macula. So now indirect ophthalmoscopy. First monoocular indirect ophthalmoscope, it was discovered in 1852, and it was monoocular, and in which light source is kept at the patient's shoulder. And in 1946, Charles Scaffens first demonstrate the modern binocular indirect ophthalmoscope. So here the light source we use is the tungsten filament halogen bulb, external source with connecting fiber optic cable. Now, how the illumination system work in IDEO? So rays of light, as you can see in the second image, rays of light from the light source in the IDEO, it passes through the lens, reflected, and getting into the patient eye and illuminate patch on the retina. And that illuminated patch then form the emerging rays, which comes out of the eye, and considering the patient eye in this case emetropic, this rays will be parallel. Now, the principle is to make the eye highly myopic by placing a strong convex lens in front of patient eye. So, these emerging rays will converge on the focal point of converging lens, and you will get a real inverted, laterally reversed aerial image somewhere between the lens and the observer's eye. Now, this rays will pass into the pupil of the examiner eye, and the image will form. So here we are not seeing the retina directly as in the case of direct ophthalmoscope, but we are seeing the aerial image. Now second principle in the IDEO is the Stren principle. In this, so when we are viewing the eye, we have three beams. First, illuminating beam, which goes inside the eye, that you're seeing upper, and lower two beams, they are the viewing beams coming out of the eye. So according to Stren principle, for having the good stereopsis and clear images, all the three illuminating and viewing beams have to fit in the pupillary area. They shouldn't be overlapping to each other and from the surrounding structure. So in small pupil, this is little cumbersome, so you will get lots of distortion in the images, and you cannot see the clear image. And when you do in the dilated pupil, they are nicely separated, and much clear image will form. Now, as we see, this both the viewing beams have to be concentrated, have to be there, have to be fit in the pupillary area. So for that, we have to reduce the observer's IPD from about 60 mm to approximately 15 mm by prism or mirror, and that is done by the optical system of binocular indirect ophthalmoscope. Now we see the principle of IDO in the ametropic eye. Now, what happened in the myopic and hypermetropic eye? In myopic eye, as you can see in the first images, the emerging rays are converging, and when it travels through the converging lens, it will converge more and falls somewhere in between the focal inside the focal length of that convex lenses. And in hypermetropia, the rays are divergent, so it will, after passing through the condensing lens, it will fall outside the focal length of this condensing lens. Now the image characteristic, so it is real, inverted, and magnified image is formed. How much magnification? It depends upon three condition. First is dioptric power of condensing lens, position of lens, and the refractive state of eyeball. Now the condensing lens magnification, the formula for magnification is 60 is power of eye upon the power of lens. For the human eye, power is 60 diopter. So this magnification is different for the different lenses. Like for 30 diopter, we have 60 by 30, that is 2 times magnification. For 20 diopter, we have 3 times magnification, and for the 14 diopter, we have 4 times of magnification. And field of vision will be inversely proportional to magnification. Like the more magnification, the less field of vision will be there. Now coming to the position of lens in different refractive error. So in emetropic eye, as we already discussed, the parallel rays will focus on the focal point of this condensing lens. So whether you go towards the, whether you put the lens, condensing lens, towards the eye or away from the eye, it doesn't matter, and size of the image will remain same. um, and in myopic eye, since the aerial image is formed inside the focal length, so when you according to the optics, when you move the lens near to the patient eye, image will look smaller, and when you move away from the patient eye, image will look larger. And in the hypermetropic eye, opposite of this will occur. When you move near the patient eye, image is larger, and you move away from the patient eye, image will be smaller. Now field of view, so we are inserting the convex lens in front of patient's eye, so rays from most peripheral area will also pass through this condensing lens, and then it converge into the pupil of the observer. So you have the large field of vision in the IDO compared to the direct ophthalmoscopy. Now condensing lens we use, they are asymmetrically biconvex, and the less convex area, the less convex side will have the white rim or white line on its rim, and it should be kept towards the patient. So most commonly used condensing lens is 20 diopter. Now we have filter wheel in the indirect ophthalmoscope. For the red, we use red free or green filter to see the vessels, to see the hemorrhage, to see the defect in RNFL layer. Blue filter is used for fluorescent angioscopy, and the yellow filter is used to protect from UV light, and it also has the it has coating also, which reduces the glare and scattering. Now procedure, since indirect ophthalmoscope has bright illumination and it is little cumbersome for the patient, so you have to counsel the patient and ask him to relax, dilate the pupil, darken the room, and ask the patient to open both the eye so that other eye will be used for fixation. Now as you can see in this first diagram, this is indirect ophthalmoscope having two bend and two knob at the top and at the back. So first you adjust the knob at the top, and then you adjust the knob at the posteriorly, so that to avoid the headache. uh, then uh, uh, then move the eyepiece lens towards the eye. Now you have to focus the interpupillary distance. For that you have to focus somewhere, for that you have to focus on the wall somewhere at the distance of 40 centimeter. Then slowly bring both the eyepiece towards each other up to the time you see the single center rounded clear images at the center. Now start with the minimum light intensity. It is advised to see to do the IDEO first in the sitting position, so that if there is any opacity in the cavity, in the medium, like if there is any vitreous hemorrhage, it will settle down and you can see the posterior pole more clearly. Then ask the patient to lying down and examine the periphery also. Now how you hold the condensing lens? So you grasp between the bulb of thumb and tip of the flex index finger, and middle finger hold on one lid, and the thumb of other hand will hold the other lid. Now you can move this lens in and out to focus on the retina. Now make you have to stretch out your hand, and you lens all have to move in as a single unit to focus. Now what happen if the patient has a small pupil? So you can do the adjustment. For that you have a knob in the bottom. As you can see in the picture, there is a knob in the bottom. So it has two settings. It has two settings, the large pupil setting and the small pupil setting. In the large pupil setting, the prism, we already discussed about the viewing beam, that it has to be close to each other in the small pupil. So in the large pupil setting, these beams are far from each other, as the prism is far from each other. And when you turn it to the small pupil setting, the prism will come close to each other, and then this both the viewing beam will focus onto the pupil. Then we can also change the setting by the lever that is present on the side, and we can decrease the illuminating beam. Now, to see the periphery of the retina between the equator and the ora, so you can do it by the scleral indentation, by creating a mound to view. And for that you use most commonly we use a thimble depressor. Now the difference between the direct and indirect ophthalmoscope. Direct ophthalmoscope give the monoocular view, limited field of vision. View is poor in the hazy media, and and the observer has to go very close to the patient. But and in indirect ophthalmoscopy, there is a binocular view. Stereopsis will be there. Field of vision will be 40 to 50 degree, and the in the hazy media also you can see the posterior pole. Working distance is 40 to 50 centimeter, but they have the magnification of only 2 to 3 times, and in direct ophthalmoscope we have the magnification of 5 times. In direct ophthalmoscope we get the virtual erect image, and in indirect we get the real inverted image. Indirect ophthalmoscope is slightly difficult to do, and it is uncomfortable for the patient since we are using the bright light. Now when you do the indirect ophthalmoscope, you also draw it in you also do the fundus drawing, so that you remember where the lesion exactly was there. So for that, most commonly we use is the Amsler-Dubois chart. The innermost circle, it denote the equator. The middle circle denote the ora serrata. So what you have to do is, when you're examining the patient, you just have to flip the chart in a position that 12 o'clock will go towards the patient foot, and 6 o'clock will be at the towards the patient chin. Now you have to draw whatever you're seeing. Like you see the disc, draw the disc as red. You see the vessel, draw the vessel. You see the tear, draw the tear. And then after this you flip it back, and then you will get the exact position of the lesion. So there are we have different color coding for each lesion. For the attached retina, we have we denote it by the red color. For the detached retina, we do it by the blue color. For horseshoe tear, we outline it with blue color, and then fill it with the red color. For lattice, we outline with the blue color and form and make crosses inside it. Then this is one more example of the fundus drawing. Thank you.
Yes, good. For ROP screening, which lens do we use?
So 28, doctor.
Yeah,
Since
why
we
do you use 28?
this will have the greater field of vision.
Yeah, correct. And usually pupil might be little smaller size,
Yes, sir.
and also axial length is much smaller in children. So generally we use higher this thing dioptric lens. Of course, we can see with 20 diopter also, but with 30D we will have bigger field of view.
Yes.
Yes. Okay. Good presentation. Any questions
Thank-
from the students?
No, sir.
Okay. So next meeting I will ask questions about direct and indirect ophthalmoscopy. Okay.
Yes, sir.
Everyone should answer.
Yes.
Okay. Thank you.
Thank you, sir.